Up next is John Irwin, comes from us from UCSF. Many of you know John from previous UGMs talking about the Zinc database, but today he's going to tell us about a new web-based application that he's been working on.
Thanks for the introduction, and thanks to the organizers for inviting me, letting me speak. I see that we're moving in slowly after lunch. Should we give people like 30 seconds more? I should start saying, my third slide is... Great. So I'll start by thanking the two people that contributed most to this work. Teague Sterling, let's see, most people look at this one, is the programmer on the project, and Pierce Ogden was a summer student who helped us out with getting some of the information in the database that I'm going to talk to you about. So if you've heard me talk about zinc, then recently you might know that we've improved zinc. And zinc is a database of commercially available compounds for virtual screening. And what we've done is we've incorporated Chemble into zinc. Chemble is the medicinal chemistry database from hosted at EBI, EMBL. And so you can now use zinc to, zinc now connects purchasable compounds with over 2,400 protein targets. So if you want ligands for proteins, and your protein is one of those 2,400, you don't need docking, you don't need similarity analysis. You can simply look up the compounds and buy them using our website. And so here on this picture, I'm illustrating a search by target. So you can type in part of the SwissProt or UniProt code or the name of the target, and it will give you with Ajax a little pop-up. And I'm looking here for HMG-CoA reductase. And then if you click on Run Query, it takes you to the next page where you're straight into zinc, just as if you had searched by similarity or by any other criteria. And we have direct links to the vendors. You can click on those links and they'll take you straight there to buy the compound. So we're really trying to make it as easy as possible to go from target to compound to the vendor to getting it into your assay. There's 20 million compounds in zinc. It's updated continuously, and there's really a lot more I could say about it, except today I'm going to talk about something else. At the same time as we've been upgrading zinc in the lab, we've also been working on the Similarity Ensemble approach. Now, I've listed 3 of the papers, most prominent papers on this work at the bottom, and I really don't have time to go into it in great detail, but let me just remind you that Similarity Ensemble approach, is a method for predicting the biological targets of small molecules, which could be drugs or could be any molecule, based on their statistical similarity to annotated compounds in the literature. And so I'll just show you how it works. So we represent proteins by the ligands that bind to them. And so for any compound, we just simply compare it against all the ligands that are annotated for that target, for instance, dihydrofolate reductase or COX-2. Compare it to all of them. We build a statistical model based on the chance that molecules are similar simply at random, based on their fingerprints. And then we rank molecules by their significance. So the nice thing about this is that we get a statistical significance score for each of our predictions. And so if you use C on all drugs, what you get is you can get a map, a pharmacological map that looks like this. So in this map, drugs are represented as orange, yellow spots. Targets are represented in blue, and there's 2 different, and the resolution's not great, but you can see it in the original paper. What we're showing you here is connections between targets based on the similarity of ligands that they bind as calculated by C. So it's a kind of pharmacological map. And some of the connections are known experimentally, and you can find them in the literature. And some of these connections between targets and drugs are predictions. And so faced with all these predictions, we thought, well, which ones of these, of course, they might not be correct predictions, but even if they were correct, which ones of them are interesting? Which ones of them might have medicinal relevance? And we had to admit to ourselves So we were faced with with pages like this. So for instance, if you take Indoramin, okay, a drug, and you run it through C, you'll get a prediction page that looks like this. And so what it's done is it said, let's see if I can highlight this. So for each target, each of these targets is represented by ligands, and it's compared Indoramin against all the ligands in each of those sets. And then it's calculated an E-value. This is similar to the E-value you get in BLAST. So it's a significant score. So closer to 0, the more unlikely it is to occur at random. And we also have the maximum Tanimoto coefficients. These are ECFP4 Tanimoto coefficients. So 0.31 means this molecule really doesn't look anything like those ligands, and yet it's novel. And so each of these predictions might be right, it might be wrong, but the question we were asking ourselves was, well, which one of them actually might be interesting for a repurposing play, for example, if you wanted to repurpose one of these drugs. And when we went looking for information, of course, you can look in Wikipedia and Google, you can learn a lot, but you can spend a lot of time on each single target trying to figure out what medicinal role it may play. And so, whereas the connections between targets and compounds, or targets and drugs, is increasingly available in the literature in the form of ChemAxon and the patent database, for example. The connection between targets and indications or diseases is much less well coded, certainly, and systematized in the literature. And this was what we felt we were missing. Of course, this does fall into the category of a target-focused approach, which has been in vogue now for well over, 25 years now. You know, before the modern era of molecular medicine, there was a more holistic approach to drug discovery. But, so, having a database that maps diseases to targets would be a useful research tool, because it would enable us to answer some interesting questions, some rather seemingly simple questions that are surprisingly difficult to answer. For example, what are the molecular targets for a disease? So think of a disease. Now, what are all the targets that have been shown to be suitable for developing a treatment for that disease? And has there been a knockout experiment, a knockdown experiment? Of course, these experiments can only be done in animal models, not in humans. For any target, for any indication, for any disease, what is the furthest progress that a compound has been made for a particular combination target indication? So is there an FDA-approved drug? Is there a clinical candidate? Is there something in a mouse model, for example? And then the way to turn that around is to say, for any given target, which diseases has it been implicated in? And this is really the question that arose when we started making these predictions. We said, oh, this compound hits leukotriene A4 hydrolase. Well, is that good for anything or not? So this is my chance to remind you that drugs actually, although we pretend, because we talk about target-focused drug discovery, drugs actually act on whole organisms. They don't act on just simply targets. Okay, seems kind of trivial to say, and yet what that means is that it's not always clear how a drug is working. So in some senses, this whole proposal I've just laid out for you to connect drugs to indications through targets might actually be the wrong way of thinking about it. Nevertheless, it's in the air, this whole idea of target-based drug discovery, and so we set about to build a system. And the system aspires to go from diagnosis to prescriptions via targets, so we call it DX, which is the Latin abbreviation for diagnosis, to treatment, to prescriptions, RX, via targets, and so we pronounce it DxTRx, and that explains the dinosaur. Anyway, we've organized it into categories of therapeutic areas that are the way that research is often organized in industry and foundations. And contrary to what I wrote in my abstract. It's now available if you go to our website, but you need to log in. So as I said, we've grouped indications within focus areas to try to make it a little bit easier to get your head around all this information. And as soon as we started doing this, a number of problems started popping up. And perhaps that is an explanation for why this hasn't been done before. Actually, I've heard that the drug companies, the big drug companies, did something like this about 10 years ago. If any of you were part of one of those efforts and would like to talk about it, I would be very interested in talking about it. So one of the problems, and there's too many problems to go over in a short talk, so I thought I'd give you just some of the outstanding problems. And one of the problems is just simply the nomenclature of indications. Okay, so on a label, on an FDA-approved label, there will be an indication saying pain or inflammation, things like that. When you go to the doctor and the doctor diagnoses you and gives you a treatment, okay, and writes and you want to get a health reimbursement, you need one of these codes. These are the ICD-10 codes. Okay, no ICD-10 code or ICD-9 code, no reimbursement in the U.S. at least. And so, there's this dictionary problem of what constitutes an indication exactly, and there's I think over 30 pain indications. You'll have heard of things like neuropathic pain versus maybe just general headache, things like that. But there's a lot of different kinds, and this goes on and on and on in the field. And so as I said, the indications that are used, for example, on the label, they'll say Motrin tablets are indicated for relief of mild to moderate pain. You can't actually, that's not a diagnosis on the, that's not a legal diagnosis code. So there's a whole dictionary problem between the way the labels are written and the way the diagnoses are written. Another problem, and I sort of alluded to this earlier, is the problem of exactly how are drugs working. And so here I'm showing you a table that I took from Wikipedia. And on the vertical axis are a number of antidepressants. And on the horizontal axis going across are the affinities for these receptors, most of them GPCRs or transporters, and in nanomolar units. So what you'll see is for these drugs that are all sort of notionally or part of the same class, they're hitting the targets, quite a few different targets at different affinities. And so if you want to have a connection between depression or anxiety, or in this case, depressants, if you want to have depression to compound, then what should the target be in the middle? Is it an ensemble of targets? Okay. The other thing about these things is that they can have knock-on effects. So you actually hit one target, but the real effect going on in the cell is downstream several cycles in a signaling pathway. The target itself is just a means to an end, rather than the end in itself. And so so is it hopeless? Maybe this task that I've set myself is a hopeless one. But nevertheless, we've created a system which allows you to navigate all through the indications, all through the targets, and all through the compounds, and you can go and have a look at it. And we're sort of still trying to figure out how to make it work for us and to try to use it to answer interesting questions. One of the things I should say is that this is a huge system, and correspondingly, we can't possibly be expected to curate it ourselves, so we had to invent a curation system. And I'm showing you one small aspect of that here, the idea that if you disagree with any particular association, for example, is CYP51 really associated with acute Chagas disease, for example? Is that really a clinical target for Chagas disease? If you're an expert in that, you can write an explanation to us, or you can change its classification. So for instance, up here, under clinical, you say, oh, actually, there's a compound. It's never been in the clinic. It's only used experimentally. Okay, so it hasn't been shown to be useful clinically. You could change its status. You could give us a PMID code, or you could give us a URL with evidence. And so we at least have created the mechanisms for a community-based curation system to capture this information. The idea would be that experts could volunteer to become curators of aspects of this database. Maybe this is just a completely hopeless idea and it will never work. It's certainly untested, but we do have one thing to go on, and that's Wikipedia. So Wikipedia, they managed to make it work. So I think it's one of those things like if you build it, maybe people will come. If you don't build it, people won't come. So I guess we'll see what will happen. And so we've got a model that allows for 4 levels of curation. So if you don't identify yourself to our system, we won't let you in. You can look at things, but you can't change anything. You can't even make a suggestion, so that's going to keep down spammers, we hope. If you're logged in, then you can volunteer to help, and you can offer suggestions, but you can't actually make any changes. If you become a curator of a page, then you can confirm or decline suggestions from these logged-in users, and you can make changes yourself. And finally, if you're a system administrator, you can do everything. And so what we're hoping is that this new tool will enable new research and new questions to be asked and answered. And I should say that we hope this is an enabling technology just the same way that ChemAxon has enabled us. So I've got this little icon down in the corner here to remind me to tell you that what we're doing here would be completely not possible without the ChemAxon tool set in behind there. But just like I think Steve Boyer said earlier, and a couple of other people have said, you don't really see it in the front end, but in the back end, I can assure you it's an integral part of our approach. And so we're hoping that the questions that I posed at the beginning become answerable with this new software. What are the targets for a disease? What's the current status? And then somehow to get a global view of this whole mapping between indications and targets, and allow for questions. For example, a researcher working in an area can simply go to our database and purchase compounds, purchase libraries of compounds for the disease model that they're interested in, including drugs, natural products, and so on. So, as I said, we've made it available. I prefer not to do a demo, but I'd be very happy to do one-on-one demos or one-on small number demos privately with you afterwards. And so that's it. Thank you for your attention.
This may be simplistic, but if you aren't for sure about the targets and stuff, why not try to make the relationship between the disease and the compound and just drop this? Okay.
Yeah, we have that too. We have that too.
Okay.
We have that too. I mean, of course, we have that already from Drug Bank. Yeah. So yeah, I mean, drugs still have indications. So it's really a triangle between, yeah. But we were interested in the target-based aspect of it. That's what I was talking about today.
So Thomson used to sell something called IDDB. Have you played around with that? And can you compare and contrast?
IDDB?
Yeah. I just went to their website and it says it's shut down. There must be a Thomson person here somewhere to comment on this. Anyway, you can go and look up drugs and target or diseases and targets and sometimes compounds, but you pay money.
But I'll go and look at that. Yeah, I'd be interested to see how they solved the ontology problem for the target naming. Another problem I didn't get into is the target naming. So, for example, sometimes people will say it's a PDE4 inhibitor, and then it'll be a PDE4A inhibitor, for example. And then the question becomes: is the selectivity a feature or a liability? Yeah.
Interesting talk, by the way. Have you looked at side effect profiles of known therapeutics to see how well that couples with off-target activity?
Yes, well, there's a lot of work right now in that area, as you know, with offsides and the work coming out of Stanford. But we do have a field, ADRs, adverse drug reactions, which we're trying to populate. The problem is, again, an ontology problem, I think, is if you take a drug and it gives you a headache, it could just be dehydration. They also, all those databases, they write down everything that patients report up to some very low threshold. So it's hard knowing what the target is for them. But there are databases of these off-target effects. We're hesitant to just include them willy-nilly in our database. We aspire to a higher level of curation.